Morning, everybody. It's nice to be here. I'm accustomed to giving talks to medical students, and you, though, are very different, and you're really quite daunting as a group. Between you, you have more knowledge than I do about lymphomas, and you certainly have more personal experience. So, I've been asked to talk about new therapies for lymphoma, and I'm going to do that. I thought it would help a bit. It certainly helps me to think about it. If I back up a little bit and talk about the biology of the lymphoma, the biology of lymphoma cancer first, and then that will put the treatments a little bit in perspective. So here we go. So this is a lymphocyte. This is the central cell in your immune system, and all lymphomas are cancers of lymphocytes at one stage or another of their lifespan, and they have a very complicated lifespan. And you also have actually three kinds of lymphocyte. I put the two main ones there, B cells and T cells, and then there are natural killer cells. They're pretty small. If you line 2,500 up, you get an inch. So they're tiny, but you can see them quite easily in the blood if you look. And that sort of ruffled surface that they have is actually quite important as well. So this is how their life cycle works. Like all blood cells, they're born in the bone marrow from grandparent stem cells that live there. So the same stem cell that gives you all your other blood cells gives you lymphocytes, and that process is very complicated. They exit the bone marrow and they travel in the blood to finishing school. And finishing school is any one of a number of what they call lymphoid organs. So it can be your lymph glands, like you get examined for every time you go, your thymus or your spleen, or there's lymph tissue in your gut, in your eye, in your lung, for example. And so they go to those places for finishing school, and then they exit. And after that, they sort of go round and round and round and round, like the body's policeman. They're looking for trouble, and if you get a cold or something, your lymphocytes will go and make antibody and kill the cold. So that's their job. And so you can see that the life cycle is very complex. And you can get a cancer at any point in that life cycle, and each of those cancerous processes looks different. He's playing music at me, is that? I don't mind, but it's okay. It's just, it's still there, it doesn't matter. It's quite nice. So I just put this up for interest's sake. This is the Bible that we use to classify lymphomas. It's the WHO, the 2008 WHO classification of lymphoma. Earlier this morning, I actually did some counting, and there are over 50 different types of lymphoma. So you can see that it's a very complex kind of a cancerous process. Fortunately for doctors, and people have to remember these things, it pans out to a relatively small number of common types. And these are the common ones, and you may recognize some of them. But if we start over here, we've got what's called chronic lymphocytic leukemia. They call it a leukemia, but it really is a lymphoma. And then you've got multiple myeloma down next to it, right there. And then as you come round, you get diffuse large B-cell lymphoma, which is one of the common ones for us. And then next, kitty corner to it, the blue, just above it, is follicular lymphoma. And then we have down the bottom, follicular is the green one, blue is Hodgkin lymphoma. And then this is a thing called marginal zone lymphoma. So if you add all those up, those are the common things that we see. That's the UK data. So not only do we have lots of different types, but in contrast to most other solid cancers, lymphomas are widely distributed geographically in people, usually. Occasionally they will only be in one place, but more often they're in lots of different places all at the same time. So you have lots of different types and lots of different places, and that really makes you have to think about how you're going to treat it. I've just put some examples up here. Bottom left with the sort of these little circular things, that's what's called follicular lymphoma down the microscope. And those little circular things are called follicles. That's why it's called follicular lymphoma. Above that, you can see a chest X-ray. And then there's a lump sticking out to the right of the heart. Right where the arrow is there, that's a lump of lymph glands. And so that's a lymphoma in the mediastinum, and possibly Hodgkin lymphoma, possibly some other type. This fella in the middle has a very impressive spleen, which is, it's a CT scan, and that thing there is the spleen. So that's actually splenic marginal zone lymphoma. Top left is the, top right rather, that's a lymph node cut. So that's what lymphoma actually physically looks like. When you take the lymph gland and you cut it, it's got this, what they often refer to as fish flesh kind of surface. It's a little black, the top one, that's probably carbon from, it's probably a lung node. And then bottom right is a PET scan. It's the same person, 2 PET scans. Black is bad in a PET scan. Dense black is bad. Sort of medium black's not bad. So the dense black on the left-hand PET scan is widespread lymphoma. Then this is a PET scan after treatment showing that the lymphoma is gone. The residual black stuff is bladder, 2 kidneys, and the heart. So that's fine. So that treatment's worked. But just to illustrate the fact that lymphomas are complicated geographically and also in the number of types that we have. So if you're thinking about treating it, surgery isn't really much help. Surgery is useful to diagnose lymphomas, but in terms of treatment, it usually isn't enough because the lymphomas are usually much more widespread than you can see at the beginning. So surgery is not on, and radiation therapy is useful, but only useful for localized areas. So as a treatment for lymphoma, you're really left with some kind of chemotherapy. So you're looking at trying to eradicate lymphoma wherever it is by giving chemotherapy. And so I'm going to talk about the new things that are happening, some of the new things that are happening in chemotherapy. And I've divided the talk up into strategies, if you like. So I'm going to talk a little bit about conventional chemotherapy, then about smart bombs, and then smart bombs with payloads, so smart bombs that carry some poison at the end of them. Talking about persuading lymphomas to kill themselves, which is actually quite feasible. We talk about getting inside the lymphoma cell and wrecking the mechanism that makes it work, which is also beginning to happen. We talk about persuading your own immune system to fight back against the lymphoma, which is also feasible nowadays. And then I thought I'd finish off with measles, because we often get asked about the measles and as a treatment for lymphoma. Okay, conventional chemo. This isn't our chemo unit, but you'll instantly recognize it. It could be anybody's chemo unit. And they're delivering conventional chemotherapy. And conventional chemotherapy dates back to the 60s, the 1960s, when it started. And it is still the central component of all the effective treatments that we have. And in many cases of lymphoma, it's curative. In some cases not, but in many cases it is. Now, conventional chemotherapy drugs are cell killers. They don't discriminate much, if at all, between good and bad. So they kill the good and they kill the bad. And so then you have to ask yourself, well, if they kill the good and the bad, how can you possibly kill the lymphoma without killing the patient? And their theory behind that is this. This is a different machine, so it's altered the, so where it says normal cells, it's normal cells it's meant to be. Okay. It was this morning, it isn't anymore. So I put normal cells in green and the bad guys in red, and then the cycles of chemotherapy are the purple arrows at the bottom. Each one is a cycle. And the idea is that each cycle will kill a proportion of the cancer and a proportion of the normal. What you hope is that the normal will recover back to normal faster than what the lymphoma will recover. So at the end of one cycle, you've had a dip in the normals and a dip in the lymphoma cells, but the normal ones got back to normal, but the lymphoma ones didn't. So just as you're feeling good again, they give you another cycle of chemo. And that's deliberate because you now know you can do it safely again, and you'll take the normals down a little bit, but the lymphoma will go down even further because it never got back to normal. So if you get the dose and the cycle frequency right, and deliver several cycles, then you can get the lymphoma cured. And that's actually the principle behind most of the regular chemotherapies that we use, like CHOP, bendamustine, ABVD, CVP, which some of you will be familiar with these regimens. And so if you do it right, at the end of it, you wind up with 0 lymphoma cells, or a very, very small number. So what's new in conventional chemotherapy? There aren't a lot of new things coming through. There still are things coming through, but this has been an area of interest for the last 40, 50 years. And so I think most of the discoveries have been made here, but we still do get improvements in existing drugs. That's just to show you a successful, this is successful ABVD. This is Hodgkin lymphoma, PET scan on the left, and dense black in the middle, and it's showing disease. And then on the right, after 2 cycles of ABVD, it's all gone. The residual black there is in the backbone, and that's okay. It's not Hodgkin lymphoma. So conventional chemotherapy works, and what we do have some drugs that give you an important advance in terms of efficacy and side effect profile. So I thought I'd talk a little bit about bendamustine. Now, it's a little cheat to call this a new drug because this was actually invented in the 60s, along with the drug that was adopted in the West, which is a drug called chlorambucil. And these 2 drugs were invented in East Germany. The West chose to continue with chlorambucil and not bendamustine. Chlorambucil is oral, bendamustine is brilliant. Yeah, that's great. I thought I was hearing things. Okay, so bendamustine is what's called an alkylating agent. They're all derivatives of mustard gas, which is a terrible cell killer. But there's a bunch of derivatives of mustard gas. Mustine is in the old regimens for MOP, and chlorambucil and busulfan, and this one, bendamustine. And bendamustine was rediscovered here a few years back. And it turns out that it is a better drug than we have hitherto used mostly for what's called indolent lymphomas. So these are the B-cell lymphomas that are categorized as lazy. We call them indolent lymphomas. So for most indolent B-cell lymphomas, bendamustine turns out to be a better option, both in terms of effectiveness and also in terms of the side effect profile. You don't lose your hair with bendamustine, which is great. This is a survival curve. These are what we often use to compare treatments in oncology and in hematology. So this is 2 what are called survival curves. So up on the left here is the probability of being in remission. It can be anything up on the left. It can be overall survival. It can be progression-free survival. In this case, it's progression-free survival. So you start with 100% of the patients at the top, and they're in 2 groups. Half of them got bendamustine and rituximab, and the others got what was standard in Europe at the time are CHOP, rituximab and CHOP, and some of you, I suspect, will have had that. And this is a comparison of how many people remain in remission as you go along, and on the bottom axis is time. So as we go out to the right, you can see that the blue line, which is the R-CHOP people, begin to relapse, and it takes about 3 years for 50%. That line in the middle is 50%, right? So about 3 years come, then you've got 50% of the people have relapsed. Whereas if you got the red stuff, which is bendamustine and rituximab, so they're identical regimens in terms of the rituximab, but different in terms of the chemo, the bendamustine people are doing better. So bendamustine we adopted bendamustine maybe 2 to 3 years back, and we've switched pretty much entirely to using that for indolent lymphomas. The other condition it works very well for is chronic lymphocytic leukemia, which is a lymphoma, really, that happens to circulate in the blood. And this is another survival curve. Again, it's progression-free survival. It tells you up on the left, same numbers. 1 is 100%, 0.5 is 50%. And then the guys that got bendamustine are taking 30 months before they get progression, whereas the chlorambucil guys, and this is an oldish study, So chlorambucil was used as the standard arm, and about 12 months before you got progression of your disease. So again, in chronic lymphocytic leukemia, bendamustine is a very good option now for patients. All right, so enough of conventional chemotherapy. What you'd really like to do, though, is single out your lymphoma cells and kill them and don't kill anything else. Which would be very nice to do, and actually not impossible. So this is, I told you that ruffled surface on the lymphocyte is really important. Those ruffles contain a whole raft of different molecules that have different functions. They signal to the cell, they allow things in, they recognize things that are foreign and so on. So this is the surface of a B cell, and what the arrow points to is a thing called CD20. So a lot of these molecules carry what are called CD numbers, which is just a coding system for them. So you have they go up into the hundreds now, and they're impossible to remember. And they're all there to do something. But on all of your B cells and mine and everybody else's, you have CD20. So if you were to aim something at CD20, it would kill B cells. It would kill your normal B cells as well as the bad guys, but it turns out that actually you can do without them, at least for a period of time. So rituximab is an antibody that's directed at CD20. So an antibody is a protein that your immune system uses to recognize specific things. So any time you get a cold, you make an antibody to cold virus, and it will recognize cold virus and nothing else. It's very, very specific. We know now how to engineer antibodies. And so we can engineer an anti-CD20, which we have done. And rituximab has been around for at least 10 years, or actually longer than that. It was talked about, I remember, in the 1990s. I remember the early discussions about it, and it took a long time for it to get to market. But rituximab is a very effective addition to chemotherapy for B-cell lymphoma. Now, the way rituximab works is that the antibody will go and sit on the CD20. That doesn't kill the cell. You need something else to come and kill the cell. And rituximab relies on a protein called complement that everybody has, which is a killer. So complement will kill cells that have antibody on them. So the antibody sticks to your cancer cell, along comes the rituximab, then along comes complement and destroys the cell. Sooner or later I'm going to really ding that. So now complement's okay, but it's not the only way you have of killing cells. And if you could persuade a cell to, an immune cell to come and do the killing as well as the complement, you might do better. And that's what I'm going to talk about now. An antibody whose name is almost impossible to pronounce is obinutuzumab, otherwise known as GA101. And on the left here, the B cell is what you want to kill. And here is CD20 on it. And here is rituximab on it. And this is complement. So that's the way rituximab works. The way that obinutuzumab works is, so this on the right here, we have, these are the antibody molecules, right? All antibodies are like a pair of trousers with two legs. And the two legs do the recognition. They're the bit that recognizes the thing on the cancer cell that's different, or the cold virus or something. And then the other end can do something else. And the other end, in this case, of the obinutuzumab, is going to bring in a death star called an effector cell, which is a cell in your immune system which can kill things. And with any luck, I might be able to show you. So the green thing is the antibody. The two trouser legs are the recognition end, and the red bit is CD20. Right? So there's the antibody sitting on CD20, and that's the surface of the cell there, that thing at the bottom. And then those things that look like moons are other cells around. So you'll see it work, I hope, if I can get this thing to go. All right, now I have to go over here. Just takes a little persuading to get it to go down, and then to play, and then to full screen. Okay. It's self-explanatory, I hope. So that's your Death Star on the right. And those are the bad guys, the B cells. Here they come with their CD20 nicely sticking out. And then the antibody comes floating by in a moment, I hope. There it comes. And that's it. So they call it Gazyva. Obinutuzumab now is the commercial name for it, Gazyva. So it comes on and it sits, it recognizes CD20, there's its recognition end, and then the other end is going to bring in, you'll see it in a minute, the Death Star, I hope. Here it comes, yeah, boom. And then the Death Star is very adept at killing cells. So that's the theory. Now, anytime you have a new theory, you have to worry that it might not work. A lot of these things sound wonderful, but don't necessarily work very well. Okay. So more survival curves. Sorry to inflict these on you. If you ever go to an oncology meeting, it's wall-to-wall survival curves, and they all look the same. They start at 100% and they go down. This is obinutuzumab and chlorambucil versus rituximab and chlorambucil. So the two are, this is in CLL, chronic lymphocytic leukemia again, but it could be indolent lymphoma for all that matter. And the top line is the obinutuzumab, and the bottom line is the rituximab. So the two groups were treated identically, apart from the fact that one lot got obinutuzumab, the others got the standard rituximab. And you can see that, again, 50% have progressed by 15 months if you just got rituximab, but if you got the other one, you got 27 months. So this is showing you that the antibody, that new antibody, which is directed against CD20, just like rituximab, but works in a different way by bringing in Death Stars as well as complement, that it works better. So you do better with obinutuzumab than you do with rituximab. So that's, I think, going to come. Now, the problem with targeted therapy like rituximab is that when you get down to it, you find that cancer cells don't all have CD20 on them. Some do and some don't. And so if you just use a very, very specific cell killer, then you'll kill the CD20 positive ones, but the guys that don't have the CD20 won't get killed. So what you want to do then is attach something to your smart bomb that will kill other cells as well. And so you can attach things to your smart bomb to kill cells. So this here is a diagram of how it's done. This is, on the left here is your antibody. So two trouser legs going up like that. And the yellow bits are the bits that recognize the thing that it's going to target. So in this case, CD20. And the green things are little pods of poison. And the formula at the bottom right is the formula of the poison. So it's an anti-CD20 carrying poison. And I hope I'll be able to show you that working too. So okay, so the blue is the antibody. Yeah. And the red is the poison. And the yellow is a linker molecule. And the linker can break down. When that stuff gets into cells, that link breaks down, the poison gets distributed. So here it is floating around in the bloodstream. You can see the red cells flying by. Doesn't care about red cells. It's looking for CD20, or no, it's looking for CD30 actually, this one. So sorry about that. It's looking for CD30. I'll explain that in a minute. So it doesn't care about the CD20. It goes flying by that, and along comes here a cell with CD30, and it's going to recognize it and latch on to CD30. So that CD30 sticks out of the cell there, and then the antibody latches on, and then lots of antibodies latch on. And then it gets eaten. The cell thinks, oh, I'm going to eat this, and it eats the poison, which isn't a very good, well, it's a good thing for you and I, but not for the cancer cell. And then the poison gets released into the cell. So those linker molecules break down, the poison goes, and it does its poisoning. And it actually works on a thing called microtubules. And microtubules actually are very important in cells. If you don't have them, the cell shrivels and dies. And that's what's going to happen to this cancer cell. One hopes. There it goes. Its last little bit of life, and then it goes. And so you can actually attach different kinds of poisons. You can actually attach radiation to molecules like that. Does it work? So that was an anti-CD30. I thought it was CD20, but it isn't. It's CD30, and CD30 is important in Hodgkin lymphoma and a thing called anaplastic large cell lymphoma. And this is another survival curve, and the details are not really important, but this stuff was given to people with relapsed refractory Hodgkin lymphoma. So that's people who've been through everything and have come out the other end not in remission, or who are resistant to the regular chemo. And it works. There's a very substantial proportion of complete remissions. That's the top line. And then it also works in anaplastic large cell lymphoma. And this man's story became quite well known about a year ago. This is an article from the UK Daily Mail. And this is the man with the lymphoma. And he was in relapse. You can see his PET scan on the left there. And he'd had all kinds of different treatments, including a stem cell transplant and stuff, and wasn't doing terribly well. And you can see how many areas of tumor there are in him. And he was given this stuff which is called rituximab vedotin. And that's what he looked like on the right. And the residual black is just his 2 kidneys and a bladder and a bit of backbone. So the cancer is all gone. So remarkably effective for some people and some cancers. All right. So the fourth strategy then, persuading lymphoma cells to commit suicide. This sounds far-fetched, but it isn't. Something like 80% of all the lymphocytes you make have to kill themselves because they're targeted at the wrong molecule. Maybe they're targeted at you. You make them randomly, and you need to get rid of them. And you have a mechanism inside all lymphocytes to do that. It's called programmed cell death. And once you initiate the program, the cell will just die. The other time you need it is after an immune response. So if you get a cold or something, you make a gazillion anti-cold lymphocytes, and then the cold goes away and you don't need the lymphocytes anymore. You've got to get rid of them. They're useless to you and you don't want them. And they will just commit suicide. Programmed cell death. This is, as you imagine, a very regulated process. You can't just have cells flying off and committing suicide just because they feel a bit down one day. You actually have to do it when you want to get rid of them. And so there's a bunch of regulatory proteins in the cell. The most important, well, maybe the most important, certainly the first discovered, was called BCL2. And that's a picture of what it looks like as a protein. Proteins have this marvelous kind of structure that consists of helixes and foldings and corners and everything. So the molecule has a shape, and that's important in its function. Well, BCL2 is it's a protein that keeps cells alive. Right? It inhibits this programmed cell death pathway. So the more BCL2 you have, the less programmed cell death you have. One of the features of lymphoma that keeps the lymphoma cells alive is this stuff, BCL2. They make more of it. Somehow they've been programmed in the cancerous process to make more BCL2 than they should have. And that keeps them alive when they shouldn't be alive. They should have died off, but they stay alive. So if you know what BCL2 looks like, and you can manufacture a molecule that would inhibit BCL2's activity in the cell, then the cell might be persuaded to undergo programmed cell death, in other words, commit suicide. There's a molecule, the molecule that's been synthesized is called ABT199. And it's only in very early development at the moment, so it's not going to come anytime soon. There have been a fair number of animal experiments done, and this is the first human experiment that was done. It goes back about a year and a bit. And since then, there are ongoing clinical trials, and I understand that about 100 people have been treated now with ABT199. But this is just to show you really quite extraordinary activity this is in chronic lymphocytic leukemia, but this could apply, I think, to many, many of the B-cell lymphomas because this protein is commonly overexpressed. So this technology is likely to broaden into other lymphomas, I think. What you've got here is a graph of what's called lymphocyte count. So basically, that's your leukemia count. So your leukemia count goes 10, 20, 30, and those at the bottom, that's hours, not days or weeks or months. It's hours, 72 hours at the bottom right. And so you give these guys a dose of ABT199, and 8 hours later, their leukemia cell count is basically down to zero. So extraordinarily effective drug. And that's been borne out in the larger study that's gone on. Something like 70 or 80% of people get a very fast response to this drug. And I think that's actually really quite hopeful. All right. Number 5, get inside the cell and wreck the engine. Again, Idleelizab and B was all one word when it started life this morning. This guy was a pediatrician in the armed services, and he described some young boys who got lots of infections. And the reason they got lots of infections is that they didn't have any antibody. And the reason they didn't have any antibodies, they didn't have any B cells. And since then, it's been discovered that the reason that they didn't have any B cells is they lack a key, what's called an enzyme in the cell. An enzyme is a protein that can do something. It can change another molecule or react to another molecule and cause things to happen in the cell. So there's an enzyme in the cell, and they now call it Brutons tyrosine kinase in his honor. And I'll show you the way it works. The two molecules I'm going to talk about, the two exciting drugs that we are beginning to get now are ibrutinib and Idleelizab, which is also pretty tough to say. Okay. This is the surface of a B cell. That red line is the cell surface. And this is what's called a signaling pathway. All cells need to be able to react to their external environment by receiving signals and doing something in response. And this is one of the many pathways that cells have, but this is the B cell signaling pathway. And that blue thing is what's called a B cell receptor. That's what sees the cold virus or whatever it is you want to get rid of. So if a cold virus comes along and attaches to the blue one tells the green one, tells the yellow one, tells SIK, tells BTK, tells PI3K, and then it tells about 100 different proteins down the line. Eventually the message gets to the nucleus, which is the control center of the whole thing. So it's a bit like beacons in the old days. When the Romans were coming, the Brits lit a beacon on the coast, and the next beacon went, and the next, and the next, and the next. Eventually the army got out of bed and went to meet the Romans, and lost, mostly. But, so you can see here that BTK is in there. Brutons tyrosine kinase. The other thing I need to tell you is that if B cells don't have this signaling pathway, they die. So they don't just need it to react to new things like colds and something. They actually need it to stay alive. If you don't have this signaling pathway, your B cell will die. So some clever person decided, well, if Bruton's agammaglobulinemia is going to work by having no B cells, maybe if we antagonize these enzymes, BTK and PI3K, maybe we can kill B cells. And so you know what these molecules look like, and you can actually engineer other molecules, other chemicals, to react with them and disable them. They're called inhibitors. And any time you see ibrutinib, it means it's an inhibitor. So if it's an AB, it's an antibody. If it's an IB, it's an inhibitor. So Idleelizab is an inhibitor of PI3K. Ibrutinib is an inhibitor of BTK. And so if you were to inhibit or paralyze either of those, you would prevent signaling and you might kill the B cell. And these drugs might be active in B cell cancers, essentially. So that's the big hope. I just want to put the next one up. This is an absurd oversimplification. This is what it really looks like. And I put that up really just to show you how many potential targets are in there and how few of them we have attacked so far. So there are many, many, many potential targets, because all of these are things that do something and their structure is known. And so you can begin to think about developing molecules, inhibitors, to repress these proteins or to enhance them and therefore influence the behavior of cells and kill cells. So the B cell signaling pathway is immensely complex. But the long and short of it is that these things work. We've gotten ibrutinib under compassionate release over the last year or so, and it's a remarkable drug. This is just one of the initial publications in the New England Journal. And what you're looking at now, it's not so much a survival curve, but a response curve. So as you go out with time, the red line shows you how many people have responded to your treatment. And you can see that this is a bunch of patients with what's called relapsed refractory chronic lymphocytic leukemia. So actually, that's a bad news thing to have. But when you got an ibrutinib, something like 70% of them went into complete or near complete remission. And the few patients that we have treated with this ibrutinib stuff have remarkably benefited from it. So it is real. And this is it in mantle cell. Again, relapse refractory mantle cell lymphoma. So you're getting substantial number of sustained responses in mantle cell lymphoma. And again, that's been our experience here, that it's worked beyond expectation. And it's relatively easy to take. You have to think about the side effects of all of these things. And I haven't dwelt on them. They all have something in terms of side effects, but they aren't too bad. And this is Idleelizab. And again, this is a response curve. And this is in follicular lymphoma, so another indolent B-cell lymphoma. And you can see that by 8 months come up, virtually everybody's had a response to Idleelizab. So two remarkable drugs. And not only are they remarkable, but I think they point the way to the future. I think knowing these pathways and knowing the mechanisms of them and understanding them leads to important advances in treatments. So I think that's one of the most hopeful things you can draw from this. All right, your immune system to fight back. Cancer cells are you and me. They're you and me gone wrong. And so they're not very different from your regular cells, but there are differences. But more in some cancers than in others. So I choose Hodgkin lymphoma as an example. When you look at a Hodgkin lymphoma lymph node, most of what you see is not cancer. Most is actually cells that are reacting to the cancer and in there, but they fail to kill it. So is there a way of persuading the immune system to kill things that are actually you yourself? It's not, your immune system's not meant to kill you yourself, but can you persuade the immune system to kill the bits of you yourself that you don't want? So I've put two new things, and they're both actually very exciting as well. Nivolumab, which is an antibody, as you can see, ends in ab, and then engineered T cells, which look very promising as well. So sorry about the complexity of this. The cancer cell is at the bottom, and your immune cell, T cell, is at the top. And you want that T cell to kill your cancer cell. That's what you really want to do. Now, the right-hand side here, from the little arrow to the right, it's all the recognition mechanism, so forget that. The T cell here has recognized the cancer cell, but it's not going to kill it because it's gone to sleep. And the reason it's gone to sleep is it's got a sleep trigger called PD-1 up here, there. So if you trigger PD-1, your T cell gets exhausted and goes to sleep, and it won't do any killing or anything. And the reason, and it turns out that the trigger, that PD-1 trigger, you see the little sort of balls going up? That's the molecule that your cancer cell makes that triggers PD-1. So your cancer cell is able to silence your immune system by making these little balls that stick onto PD-1 that make the T cell go to sleep. So if you could ever find a way of stopping that happening, your T cell might wake up and do the cell killing. And that's what nivolumab does, or nivolumab, yeah, I got that right. So this nivolumab is an anti-PD-1, and it's shown there. Right? So there's your antibody, the two trouser legs, and that antibody will recognize PD-1. So if you put that antibody in, it will stick on PD-1. Those little blobs, the sleep-inducing blobs, won't be able to attach anymore. They get blocked. They can't get on there. So the T cell will wake up and do some killing. So that's the theory. Does it work? And the answer is yes. So this is, again, relapsed refractory Hodgkin lymphoma, difficult disease to treat. Conventional approaches often don't work very well. And this is 23 patients treated with nivolumab. And this is a slightly different graph. So at the top there, each bar represents the percent decrease in the cancer. And each bar is one patient. So the first guy only got 20% reduction. That's not great. But the last few guys got 90 to 100% reduction in their Hodgkin lymphoma just by giving this antibody. In other words, you're waking up your immune system and it's actually killing your Hodgkin lymphoma, which is great. This is a phase 1 study. Phase 1 is early, so this is a way off yet. But I think this is likely to come. And to me, it looks very exciting. Now, this is really neat. I mean, this is so clever that very few people can do it. Although I know that some of the big pharma companies are interested in this and are working on making it available. But we all have T cells, and our T cells are capable of killing other cells, and by and large, they don't. For most lymphomas, they don't actually kill the cancer cell because they don't recognize it properly. So the question is then, could you take normal T cells from an individual and reprogram them so that they're going to hone in on the cancer? And the answer to that is again, yes, but you need a fancy bit of genetic engineering to be able to do it. So the way T cells recognize the thing that they're meant to recognize, in this case a cancer cell, is that they have a receptor on their surface. And that's that thing there. Now, normally you don't have receptors. All B cells have another thing on them called CD19, right? You have CD20, I've told you about that, but they also have CD19. And all B cells have CD19 on them. So if you could kill CD19 cells, essentially you'd kill B cells and kill the cancer. But you don't normally make a T cell that is directed at CD19. Otherwise, you'd be in trouble, but with infection probably. But can you engineer a T cell to attack CD19? And the answer is yes. So what you do is you make an antibody to CD19, and you get the gene for that antibody, and you hook it up to some other genes that cause T cell activation and stimulation. So that top thing is a little genetic package. It'll make a protein that recognizes CD19, and it'll make protein that activates a T cell and makes it get into killing mode. So it's a synthetic piece of DNA. And now you've got to get it into your T cells. So what you do is, if you come to me with your cancer, I take blood from you and extract your T cells, and I take this little viral package thing that's got the DNA in it. So that squiggly thing in the middle is actually this thing, much smaller, right? And that little package can be delivered to your T cells. So I stew the two together, grow them up for a bit, and I get this guy at the bottom. It's called a chimeric antigen receptor expressing T cell. So it's a T cell that's expressing this thing you just put in. And that thing you just put in will recognize CD19. And then you give them back to the patient. And the patient then gets a response to their cancer, because these T cells you put back in are live. They'll recognize the CD19, they'll get stimulated not only to kill, but to multiply. So you'll get more of the T cells and they'll do killing. And they should stick around for as long as you've got any CD19 positive cells. And so you should be able to induce a remission in your cancer. Now, as I say, this kind of immunological engineering is beyond most institutions at present, but might become possible with support from Big Pharma. But it looks pretty spectacular. Another survival curve, I'm afraid, but this is acute lymphoblastic leukemia, which is kind of a lymphoma of lymphocytes right at the get-go. When they're just being born in the bone marrow, if you get a cancer then, it's usually an acute leukemia. So this is a kind of a lymphoma. The strategy has been used in actual lymphomas as well. It's been used in diffuse large B-cell with success also. So the strategy is not confined to leukemia, but this happens to be leukemia, and this happens to be acute lymphoblastic leukemia in relapse, and it's adults and children. And again, this is a condition where you would not expect responses to occur, and you wouldn't expect survival to occur. And this is overall survival in quite a large number of patients treated with chimeric antigen receptor T cells. So you start at 100%, and then 2 years later, you've still got 80% of the people alive and in remission, and that's extraordinary. You know, with the technology we currently have, we couldn't expect to get anything like that at all. That's just, well, it's mind-boggling. So this is coming, I think, and it's coming not just for leukemias. It'll, I think, come for lymphomas as well. When will it come? I don't know. It is likely to be years, I think, but very, very promising. And then I put this in. I don't find it especially exciting, but the center that does it thinks it's great, and I think for some lymphomas it might be. This is actually multiple myeloma, and that's measles virus. And viruses are very clever. Viruses have recognition sequences that are expressed on their cell surface, which will make them go into some cells and not others. So if you could find a killer virus like measles that would only go into your cancer cells, maybe your cancer would die. I mean, the hypothesis is perfect. So what these guys have done then is to take a measles virus strain. It's not just straightforward measles virus, it's an attenuated measles virus. And it happens to attach to a certain cell molecule called, I think it's CD44, but I could be wrong. And it will go in those cells. And it turns out that myeloma cells have a lot of that receptor on them. So this virus will preferentially go into myeloma. And they published they tried it out in patients, and it worked. It worked partly in one patient, and it worked beautifully in another. I haven't seen any further studies on it yet, and I don't know how generalizable this will be for lymphoma at large, so to speak. I suspect not, but it may be a strategy that's useful for some people. I'll just show you what they achieved. The neat thing about the virus is they hook it up to a molecule which you can detect using imaging studies. And so what you're looking at here on the top, that bump of yellow, is what they call a plasmacytoma, which is a piece of multiple myeloma, a solid piece of multiple myeloma. And that's pre at the top. And then after the measles virus was given, it goes away. So for this patient, it actually worked very well indeed. So some promise, but I think the difficulty is going to be engineering your virus to attack the things you want to attack. But maybe that's possible. It's not beyond the wit of man to do that, to re-engineer a virus to go some different place than what it normally does. And if you could do that and make it specific, maybe that will come. So certainly there are institutions that are very interested in that kind of technology. I am nearly done. Before you. So, as my bio says, I did actually train quite a long time ago. I was thinking about it actually. My textbook on lymphocytes said lymphocytes are a cell in the blood of no known function and probably are just there because they're going to die and depart. Right. So nobody knew what lymphocytes were, nobody knew what they did, nobody knew the different types, T's and B's, and natural killer cells. Nobody had any idea of the genetic mechanisms. Watson and Crick actually had only just when I started to train, they had just published their double helix stuff, and nobody knew very much about the structure of antibody. And then you look at that diagram now that I showed you of the B-cell pathways, an enormous scientific knowledge now compared with what there was. And there is an enormous inventiveness. It's just huge. The things that people are interested in, 90% of them will go down the tubes and won't work, but some of them will. So I think that's, to me, it's a message of hope. I think I would be more hopeful now than I would ever have been, just looking at what we know, and in particularly in lymphoma, because we've got a good start with the conventional chemos, unlike many of the solid tumors. So I think there's immense hope for the future. So with that, I'll leave it, and if you do have any questions, you can ask me, and luckily I've got some backup over here that if you ask me a question I don't know the answer to. Yeah,
15 minutes.
Sure, that's fine. Yeah, no, that's okay.
Yeah, so we can actually welcome questions now. We have some time before Jill does her presentation. So if you just want to repeat the question.
I will, yeah.
So raise a hand.
Go ahead.
I believe the re-engineering of the T cells, chimeric antigen receptor, it's currently they're doing CD19, but I think Dr. Carl June, I think it's Penn State, I'm not sure, is one of the people doing that. But they're focused on CD19. So CD20, would they need to re-engineer the whole mechanism for CD20 to treat a different kind of cancer, or is typically all lymphomas got a CD19 that can be targeted?
Right. So the question was whether we would re-engineer T cells to attack CD20 instead of CD19 to get a different kind of a cell. To my knowledge, the answer to that, if you wanted to engineer a T cell to attack CD20, yes, you'd have to rejig that whole construct. Well, not the whole construct. You would have the activation bit, that would be fine, but you'd have to stick on the right-hand bit, which is the recognition bit for CD20 instead of CD19. I would guess that that's probably not worth doing because both of them are pretty ubiquitous molecules on B cells, and actually CD19 is a bit better, I think, because it actually extends further back in the lifespan of a B lymphocyte. So you would actually get more with the CD19. So I don't think you would see it re-engineered for CD20, but you could re-engineer it for anything you wanted. If you had something on lung cancer that you could engineer in, why not try that too? So I'm guessing that this technology is going to branch out very considerably. The problem is, I think, the technology and the expense and the expertise you need to do it. But I know Novartis is interested in it, and if they can make the constructs and make them available, it isn't too difficult to take T cells from a person. That's not too hard. And here in Queens, I'm sure we could do that. And if we had, it's not too hard to mix them together. So if the construct's available and you just mix it together, incubate it for some time, give the T cells back, I could see it working. I mean, it's going to be a tertiary care institution type thing. It's not going to be something you do at home. But I could see it being an important part of the future and feasible. And I think that's what Novartis sees in this too.
My understanding of that treatment is that the tumor-lysis, the death of cells, is the big problem with because it's so effective.
Yes. So the question was about what happens when you give this drug and kill the cells. So there are side effects to everything, and I think the early patients with this got a thing called cytokine release syndrome. So the cells release all kinds of chemicals that act on other cells and make you sick, and they had trouble with that. There are ways around that, though. You can give antibodies against the chemicals you release, and that will ameliorate the problem. So that's true, but I think that is surmountable, probably. Go ahead.
My question is, I think it was the number 2 that you had on your list.
Yeah.
Is that actually being used as a treatment now? And if so, it appears to work more effectively than the bendam and the rituximab. So why wouldn't that, I think that was what you called the Death Star one?
Yeah, the Death Star one, yeah.
Is it being... Like,
It's not being used here yet, no. We don't have approval for its use yet. So the question was, are we using obinutuzumab? Sorry, I knew I wouldn't be able to say it. And the answer is, and the answer to that is no, we're not using it yet. There are a number of steps between proof of efficacy and use in the clinical setting, and it relates a lot to funding. In fact, it relates almost exclusively to funding. So Ontario has a funding mechanism that works, but it works slowly. And they look at, and these drugs by and large are very, very expensive, which is it's another discussion, I think, but they are. So no, but the Ontario mechanism looks at efficacy. It looks at whether the new drug is an advantage over the old one, and it looks at whether how much it's going to have to pay, and then it decides whether it's going to fund it, and if it does, then it puts some criteria in, and then we can use it. Go ahead.
There was someone else. Okay. Many of the drugs that you spoke of in the tiers and
Yeah.
within the charts, the documentation is for relapsed and refractory.
Yes.
Which I understand is critical. What about recurrent? I mean, are any of those coming down the line for recurrent patients?
So the question was, are any of these new molecules coming down the line for recurrent patients? Yes is the answer. So typically when you use a new agent, you want to know whether it's going to be effective or not, and you have no idea. And so you naturally take patients who really don't have a lot else. And if you strike lucky with one of those molecules, you're a winner. If you don't, you aren't. So they usually get used in the relapse refractory setting to start with, and that's usually where they're approved first. And so we do have the ability to get, for example, ibrutinib for relapsed disease, and certain varieties of chronic lymphocytic leukemia that we predict are not going to do well. So yes, they're becoming available, but many of these are in phase 1 clinical studies, and they're not yet going to reach the clinical floor, but I think they will. And if a molecule is extraordinarily effective, sometimes they get fast-tracked too, so it doesn't necessarily take the rather long time it sometimes seems to take. Go ahead.
Sorry, just briefly, how many phases does it go through before it gets available for?
So the question was about drug approval, and I'm not an expert on it, but I'll tell you there are 3 phases. Phase 1, so you get animal studies first, right? And usually you put a tumor in a mouse and give the mouse the drug, see if the tumor goes. And then you do a phase 1 study in humans, and that's basically a dose-finding exercise. It's not really to look at efficacy at all. You give the drug to a certain number of patients, and typically you'll change the dose and figure out somehow what the side effects are and what the limiting dose is going to be and the limiting dose toxicity. Then it'll go into phase 2 clinical studies, which are efficacy studies. Often they're not randomized clinical studies. They can be single arm. So you'll put the drug into a bunch of CLL patients or a bunch of follicular lymphomas or a bunch of relapsed diffuse large B cells, see how they do. And if it looks good, then to prove that it's better than what you already have, this would then take you into phase 3. And you would take a bunch of patients with standard treatment and a bunch of patients with what you propose is going to be better. And then you randomize them into those two groups and you do a study. And those are phase 3 clinical studies. And those are typically what are needed for drug approval, regulatory approval. And those are very expensive. They involve, well, for the cardiac drugs, it'll involve tens of thousands of people. For lymphoma drugs, it's usually a lot less than that. But even so, they're expensive to run. And they're typically done in multiple centers across the country and often across the world. So here in Kingston, we have the National Cancer Institute Clinical Trials Group. And they're the Canadian coordinators for clinical trials like this. And they coordinate centres in Kingston, in Vancouver, in Calgary, all over the country. And they also cooperate with clinical trials groups in the US and in Europe and very extensively across the world. So it's an expensive and rather prolonged process, unfortunately, but those are the phases. So most of what we talked about were in phase 1, but exciting looking molecules, but there's a way, the studies take time too. Go ahead.
Yes, Doctor, you didn't seem to differentiate with Hodgkin's lymphoma and non-Hodgkin's lymphoma, which I suppose you've been treated for since 2009.
Yeah.
And I'm just wondering, why would that be?
The question is why I didn't distinguish Hodgkin lymphoma from the other lymphomas when talking about it. Well, in fairness, I actually did. I talked about Hodgkin lymphoma and nivolumab, and Hodgkin lymphoma responds to nivolumab, and you'd predict that from the immune response. But the truth is that Hodgkin lymphoma is just another B-cell lymphoma. For many years, nobody understood what the Reed-Sternberg cell was. Actually, for a large part of my career, nobody knew what the cancer cell in Hodgkin lymphoma was. With modern technology, you can actually pick off the Reed-Sternberg cells and show that they're B cells. So Hodgkin lymphoma is a B-cell lymphoma like diffuse large B-cell, like follicular, like all the other B-cell things. What causes Hodgkin lymphoma to be different is your immune system's reaction to it. So like I said, if you take a Hodgkin lymph node and look at it, you see very few cancer cells, but you see a whole raft of immune cells. So Hodgkin lymphoma is distinguished from the other lymphomas by the immune response to the cancer. And that makes it very different. It makes it much more responsive, it makes it responsive to regular chemotherapy drugs. They work very well and the cure rates are high. But it also makes it different when you're thinking about tweaking the immune system. If you can tweak it a little bit in Hodgkin lymphoma, you might do a really great job because it's already geared up to work. So Hodgkin lymphoma it's the same in the sense that it's a B-cell lymphoma, but it's different operationally in the sense that it's treated differently and the immune response to it is different and the long-term prognosis is different. So operationally, we still divide lymphoma into Hodgkin lymphoma and everything else.
Okay. Now, my understanding of the difference, fundamentally from a layperson point of view, I suppose, is that Hodgkin's lymphoma can be cured, but non-Hodgkin's cannot be cured?
So the question is, Hodgkin lymphoma be cured and non-Hodgkin can't be cured? That's actually untrue. Hodgkin lymphoma can be cured, and so a decent proportion of non-Hodgkin lymphoma can be cured also. Just in kind of simple terms, when we treat diffuse large B-cell lymphoma, which is one of the big slice of that pie, we're treating that for cure if we can get it. We don't always get there, but we aim at cure for those people, and we actually get there in a substantial number of people. For the indolent lymphomas, there isn't currently a strategy which we know to be curative. We do get some very prolonged survivals with conventional treatments and also with stem cell transplant, but the message we give to those patients is that we can control the lymphoma but not cure it. But many of the other non-Hodgkin lymphomas we can cure.
So I think we'll take one more question,
Sure.
and Dr. Matthews is also going to stick around at the end for the survivorship panel, so he can take more questions at that time. Any other questions? Okay, you'll have time to think for later. So thank you so much for your great presentation. I have to say that when I hear doctors present on new and emerging treatments, you know, I hear that a lot, this is one of the best explained presentations that I've seen. So we're really grateful for your expertise.
Thank you.